Okay, ladies, gentlemen, I'm Don Lindbergh. I'm Director of the National Library of Medicine. It's my pleasure to welcome you to the Joseph Leiter Lecture. First, a moment on the lecture itself. This is a creation jointly by the Medical Library Association and the National Library of Medicine, this current spot in which you are housed. And the lectures occur alternating years, either at the MLA meeting or at the National Library of Medicine. And luckily this year, the lecture will be held at NLM. So you're here all for the right purpose. You'd be surprised if I said something different, wouldn't you? Like Benchley once said to a sort of a sparse audience, you're not sparse, you're overflow, but he said, you look like nice folks. Why don't we get in a taxi and go somewhere? Well, I won't delay you by naming anything like all of the wonderful honors that have been bestowed upon D.A. Henderson. But I do want to touch, he's an old friend, and I'm very proud to say that, and I've seen him through a few of these, so I have to at least mention his role in the Office of Science and Technology, his deanship at Johns Hopkins, the School of Public Health, which is a distinguished school and a distinguished deanship. So he's Dean Emeritus. Right at the moment, though, he started, well, before any of those things, he did something that I felt was fantastic. He came within millimeters of freeing the world of smallpox. And were it not for political complications, I think we could underline that and say, double stop, done. But it was his genius to create a strategy that essentially eliminated naturally occurring smallpox cases from the world totally. I hope he'll tell us something about that, because he certainly has every reason to be enormously proud. Just at the moment, to bring it up to date, he is director of the Johns Hopkins Center for Civilian Biodefense Strategies. And that has to do, of course, with being alert to emergencies. And it has turned out that he and the center were more alert to the emergency presented by an offer from the University of Pittsburgh than was Hopkins. So it's now the University of Pittsburgh Center as above, and I think that's wonderful, and we'll welcome any remarks you care to give us. I should give you a title, Plagues for the 21st Century, a Communications Challenge. Please.
Thank you very much, Don. I appreciate the very kind introduction. I usually have to point out what did I learn from that smallpox experience. And I've been asked that on a number of occasions as to what was the basic lesson that I learned from that. And the fact was that we'd been 11 years and I'd become an international expert in the disease, which was a very nice position to be in. The only trouble was, came 1977, there was no disease. And there you are, what do you do with no marketable talents at all? Where do you go? And so I became a dean. But let me say I'm very pleased to be here, and members of the Medical Library Association, who I think many are here, and staff of the National Library of Medicine, and friends and colleagues. You do me a special honor in asking me to present the Joseph Leiter Lecture this year. Indeed, it's a special pleasure to do this, and particularly with medical librarians who represent, I think, one of the important unsung heroes of medical science, and who contribute a lot with very little credit. And what a task they have now in trying to grapple with the tremendous wave of information and new approaches, albeit with inadequate resources to do so. I know they're inadequate resources because when I was dean and we reviewed the budgets every year, I was informed at great length of how inadequate the resources were, and no matter how much they grew, they were still inadequate. And but actually I think they were right, but there was a limit. My focus, as you requested, is on certain aspects of the role of information in global public health, and for reasons that I will describe, the 21st century has already made it quite clear that we can expect an exponentially growing array of challenges from the microbial world in the form of infectious diseases of many types. Certain of these challenges, as I will note, could be potentially more devastating than any in history. And to cope with them, it is critical they be detected and characterized as rapidly as possible. A real challenge. It is essential that we have systems for the exchange of information rapidly, doing more than we are accustomed to doing. And we're going to have to depend more on multinational networks of laboratories and scientists to cope with these. There's no question but the medical libraries are going to play a very critical central role in this. And I believe we're especially fortunate to have leading this effort the National Library of Medicine. There may be questions about global trends in Americanization occurring as a result of Hollywood and McDonald's and Kentucky Fried Chicken, but I never hear a comment about the National Library of Medicine other than to say, more is better, send them on. So let me say it's a great honor for me to be here and with this group. As I begin the discussion here, I think it's important to emphasize this note from Josh Letterberg, that man's only competitors for the dominion of the planet are the viruses, and the ultimate outcome is not foreordained. And certainly we have an amazing biota out there, constantly growing, mutating, changing, with all sorts of organisms endeavoring to gain a foothold, an upper hand, and we can predict that there's certainly going to be more problems. And the competition is clearly increasing. We've had, from several sources, we can see threats from the natural mutation of organisms, from the emergence of organisms from remote areas, such as we've seen with AIDS, to the biological terrorism. The important point to make is that the threats are international. The solutions will neither be simple, nor will they be inexpensive. I would remind you that back in the 1950s and 60s, 70s, we had a perception that the infectious diseases were no longer a problem to us. And indeed, we had many dramatic changes which occurred post-World War II, from vaccines to nutrition to sanitation. And with this, we saw a marked decrease in diseases everywhere. We also saw that departments of microbiology disappeared, and the number of medical schools, training programs for infectious disease physicians diminished. And indeed, as I was just going to my graduate training, it was strange to be heading for infectious diseases at a time when everybody was assuring us that the end was there, and particularly this was the comment from Sir McFarland Burnett in 1962. One can think of the middle of the 20th century as the end of one of the most important social revolutions in history, the virtual elimination of the infectious diseases as a significant factor in social life. A remarkable statement. Certainly this was not true in the developing world, but the perception in the industrialized world was that there had been a real change. And so the emphasis on the chronic diseases as being now our challenge, and so it went. But I say the first cloud on this horizon was very memorable for many of us, was those first cases of AIDS being detected in 1981, then coming up with April of 1984, when we had the triumphant announcement that the virus had been identified, and Secretary Heckler's comment that we will have a vaccine available in just 2 years. Well, what do we have now? We have a worldwide pandemic in progress. It's the fourth leading cause of death worldwide. We have no vaccine as of now. We have no curative drug. We have drugs that are ameliorative and postpone death, but they're not curative. And this is one virus which is having a tremendous impact. It will not be the last. 1989 was a time I remember particularly well. We had a conference on emerging infections at the Fogarty Center. And at that time, there was a discussion, is it possible that we could have other agents like AIDS? Would we expect anything like that? And I recall one discussion over the question, is it possible we could have a disease like AIDS with a very long incubation period, which spread very rapidly? And by the time we actually were identifying it, that really you had a worldwide infection. And the conclusion out of all this was you couldn't rule that out. It was not an impossibility. And of course we did have something somewhat like that, or it looked like this for a while, with the bovine spongiform encephalitis, the mad cow disease, where by the time this was characterized with some 10 or 11 cases in the UK, it was estimated that some 500,000 animals potentially infected had entered the food chain. So, but fortunately, this did not occur, did not result in a massive epidemic. It's only the question, could it? Now, as an illustration of where we are, just these are the last 3 years. We've added to, in North America, a new inventory of disease. We had the SARS, as you recall, from Asia. We got monkeypox from Africa coming in on giant African rats. We had anthrax from goodness knows where. We don't know where that came from, but it's certainly distributed from the United States. We've had the mad cow disease, and we've had H5N1 influenza in chickens in Asia, but the question is when or will we have H5N1 here? I'll come back to that. Now, there are reasons why we can be concerned about infections from around the world. And I think many people don't realize the major changes which have taken place just in the past decade or two. For example, with urban populations, actually in 1950, we only had 2 cities in the world with more than 5 million people. That was London and it was New York. We come to 1975, we got 5 cities with more than 10 million population, 2020 with more than 10 million, and 6 with more than 15 million. Many of those cities are in tropical or subtropical areas where people are densely crowded, sanitation is poor, nutrition is bad, and if ever there were a situation ripe for a new organism coming in or changing and spreading, it certainly is now in a very different way than anything we have experienced in history. By 2015, it's estimated we'll have 5 cities with more than 20 million persons and 55% of the world's population living in urban areas. The second item that is certainly a major change that's taken place is international travel. And surely you all are fully familiar with this, but 1.8 billion commercial air flights in the year 2000, 18 million commercial air flights, 1.1 billion air passengers, and going across the world, everywhere. And so the potential for transmission is enormous. The third is the growth of hospitals in endemic areas. One would assume that this would be a positive, but in fact this creates a problem. Certainly with smallpox, we did our best to keep smallpox patients at home because we knew getting into the hospital, whatever was done, however much there were efforts made to isolate patients, it never worked terribly well. And so these were the great sites for spreading of smallpox. And today we have in so many developing countries a lot of infectious disease, people going into hospital, and this serving as a potential for spread. Many of the hospitals are with very limited supplies, very limited needles and syringes and what have you. And so we see the potential for bloodborne diseases being tremendous. And indeed, certainly Ebola outbreaks have been related to this. Lassa fever outbreaks have been related to this. And finally, this is a place where we do encourage antibiotic resistance to develop. And so the number of hospitals we have has enormously increased, and the number of hospitals in the poorer areas is much greater. The third is that a big change, a fourth major change, has been the food supply, where there are many examples of this, but something like 70% of fruits and vegetables coming from developing countries, industrialized production of cattle and pigs and what have you, so that anything that gets into a herd is likely to spread, and we know that we have antibiotic problems as a result of feeding of antibiotics to animals. There are those who worry about going to maybe South Asia or Africa and eating food in some restaurant or other. Actually, they can do pretty well just going down the street to the local grocery store, because most of that's on the shelf already and not any better screened than what you have going to picking it up in the local country. So these are major opportunities for organisms to get started and to spread, and certainly we're going to see much more. And finally, we have the international intentional release of biologic agents. And this was a threat which I can say was largely ignored until 1995, and certainly between 91 and 94, I was in the White House at the Office of Science and Technology Policy, and I can say that there really was not a great deal of concern about this. Troops were vaccinated. 150,000 were vaccinated against anthrax going into the Gulf War, but we were dealing with millions of people over there, so it really was not taken quite that seriously. But in 1995, it began to change, and the argument was it was just difficult to grow the organisms, technology is difficult to disseminate them, and they're seldom used because there's some sort of inherent moral barrier that would militate against it. Well, each of these has been found to be totally wrong. The 1995 release of sarin gas was one major factor that really caused a good deal of concern within government and with regard to policy. The Aum Shinrikyo who were involved were previously unknown to our intelligence and really not well known to the Japanese. They had thousands of members. In fact, they were closer to tens of thousands. They were well funded. They were doing a great deal with computers and programming and so forth. And they had some very intelligent people. And they tried to aerosolize botulinum toxin a couple of times, and anthrax, I think it's 6 times, throughout downtown Tokyo using a commercial truck with a commercial sprayer in the back. And nothing happened. And as we managed to get the organism since, we now know that it was the Stern strain of anthrax, which is used as a vaccine. And it really is deliberately grown not to be virulent, so that that's why they failed. And indeed, they went off to Congo at one point, trying to obtain samples of other viruses, and a group was over there. But here we were with an unknown, non-state-sponsored organization acting without concern for moral deterrence. So it wasn't necessarily a country that was involved with here. Here we were dealing with a cult. Could there be others? Yes. The major concern was that of the Soviet Union. In 1973, there had been the Weapons Convention, International Biological Weapons Convention, in which countries agreed to destroy such stocks of biologic weapons as they had and not to engage in any research on offensive weapons. And then in 1989, there was a defector from St. Petersburg who came to tell the story of working on a plague organism which would be resistant to antibiotics, and telling that there were other activities going on in the Soviet Union. And this became immediately top of the list of agenda items for President Bush and Margaret Thatcher when visits with the Soviet leadership. Then in 1992, Ken Alibek, who is deputy director of the Soviet bioweapons program, deserted and brought with him this incredible tale, which was not believed for some period of time, that there were at least 60,000 people working in 50 different laboratories. Some of their very best people were working on biological weapons. And eventually this was able to be confirmed, and parts of this in different ways, but it quite clearly was a major problem. These two events precipitated then concern about biological weapons generally. And the more alarming bit was Ken Alibek was writing about this in his book, that it was on May 8th that they decided in the Soviet Union to include smallpox as a specific weapon which they would develop and for use in intercontinental ballistic missiles and in cluster bombs. And it took some 5-6 years to perfect the large-scale production of this. Eventually they did, and they were capable of producing in excess of 20 tons of smallpox virus in a year. The principal plant for that is at Sergiev Posad, about 45 miles north of Moscow. And that plant has been a secret facility of the Ministry of Defense, and still is there and still inaccessible to anybody from the West or indeed from the Soviet Union either. So today, as we have with more than half of the scientists no longer working in these laboratories, many have gone abroad. We have some very good scientists in the United States, I think some here at NIH. They've also gone to many other places, sometimes in residence, sometimes as consultants. And the question is, what have they brought with them? Well, obviously they have brought with them the knowledge of production of biological weapons. Have they taken with them material? We really don't know. Has any other country gotten smallpox virus? We really don't know the answer to that. One can only speculate. And then it's only 2 years ago that the former Vice Minister of Health, Petr Burgasov, admitted that they had been undertaking aerosolized studies of smallpox, open-air aerosolized smallpox on Vaz Island, where is this island in the Sea of Aral. And so the concern about this being one of the major problems that threats or challenges, along with anthrax and plague, that these were three of the big three. And this was the Group A list that was developed in 1998 when we asked the question, what organisms could threaten the integrity of civil government? So that you could use any number of different organisms as agents to have outbreaks. But what would actually be so serious as to threaten the integrity of government? And those are the 6, but as we've continued to work and deal with this problem, it's smallpox and anthrax are the 2 about which we have been most concerned, and smallpox in particular, because on September 11th, in fact, 3 or 4 days later, we had a meeting in Washington to say what would happen to smallpox, where to be released. And the comment, there was cable traffic at the time, suggesting what was going to be a second episode after the World Trade Towers. And we speculated it might well be biologic because of the things hardening up. So far as air traffic was concerned, it would be more difficult to repeat. And so we asked, how much smallpox vaccine do we have? Well, we had exactly 90,000 doses that could go out the door at that time. We had 15 million left over from 1978, but we had only 90,000 that we could actually use. There's no vaccine producer anywhere in the world at that time, and wasn't until 2002. And the amount of vaccine that anybody had at that time was what had been produced back in the 1970s before eradication. Fortunately, the whole vaccine holds up pretty well, but worldwide we were dealing with millions of doses. And the concern of smallpox getting started and spreading, a disease with a case fatality rate of about 30%, we could see as a real catastrophe. Right now we have produced the vaccine. We have some 300 million doses in the U.S. at this time to be used should it be needed, and I think many of us are sleeping much better than we did. Anthrax is a problem still with some problems to be worked out here. And the one very major problem is influenza, which I think worries us as much or even more. Because if you recall, 1918 influenza, the swine flu, the H1N1, in the course of a year, and with a case fatality rate of only about 1%, resulted in 550,000 deaths in the United States alone, and in excess of 20 million worldwide. There are various estimates made. 20 million is the lowest estimate. There are others who said it's probably closer to 40 to 60 million people died. Well, at this time, we have in South Asia now, I guess the first cases were in 1997 in chickens, and a very devastating disease for chickens, and humans were working closely with the chickens, were coming down with the disease. Not many, but I think the latest tally, I may be a little behind on this, that up till now, 2004, there have been 35 cases. 23 of those people died. So this is a disease to be regarded with some concern. Now, it is obviously spreading through wild bird populations, and it's present in quite a number of countries in South Asia. And the question is, at what time is it possible that can change and begin to spread in humans? Because none of these cases, with possible exception of 2, have spread from person to person. And this is the real concern right now, and why indeed we're in the process of taking a number of emergency measures at this point, but we're by no means prepared to deal with this problem should it suddenly erupt. But that's another long chapter and not to be talked about now. It is only to say that this could be a serious, very serious disease indeed. Now, one of the things that has absorbed me during my career has been the question of surveillance. How do we find out what is going on in the developing countries in particular? And my experience, I was head of surveillance section at CDC for some 6 years. I then was responsible for the smallpox program, and which we had to set up reporting systems across the world to find cases. And then I was working with Cerro de Quadros and the Pan American Health Organization group in developing the methodology for reporting polio cases in the Americas, a system which has since been extended worldwide. Now, in the course of this, there are any number of people with enthusiastic people who would like to know a lot more about what's going on in the developing world. What have we got in the way of disease? How do we detect new diseases and so forth? And there's a remarkable misinformation that people have. They somehow either feel there's a lot of data out there. If you dumb epidemiologists would only get out there and start mining this data, you could find out an awful lot about what's going on. Well, you say, well, what do you have in mind? What data do you think we could get? Well, routine reports from health centers. Well, I can tell you most health centers really aren't interested in sending in reports, and trying to get people to do this on a regular basis is not easy. In fact, even in the Washington, D.C. area, they had troubles getting the military outpatient departments to record data on a syndromic surveillance basis because they just didn't have time, and they had real troubles implementing it, even in the U.S. in the military setup. Well, they say, well, death certificates, you can certainly follow those. Well, good news, people. Most of the world doesn't have death certificates, and there's nothing you're going to get from the developing countries there. Well, what about getting reports from hospitals? And then the question is, well, there are an awful lot of people who get sick, don't go to hospitals, and hospitals really aren't much better organized than the health centers. Trying to get reports from hospitals is extremely difficult. Well, how about laboratories? Well, good news, there aren't that many laboratories doing diagnostic work on specimens. Well, maybe we could do special surveys. Well, good idea, but then, well, do a special survey, you do it, and it's over. And it's a cross-section in time when you're trying to follow, to try to detect, let's say, unusual cases that might have popped up at any time. And finally, there's something that has been invented in this country called syndromic surveillance, where you only ask people to report people being seen in outpatient departments or what have you, whether they have a respiratory disease or diarrhea or rash or what have you. And as you can imagine, since 9/11, we have, I think, anybody who has a computer has developed some sort of surveillance, quote, surveillance data system. And we have, I think, since I've been working in the Secretary's office, we have been entertained by I don't know how many of these and reports of them. All I can say is it's a wonderful idea. It's experimental, and nobody's demonstrated they detect anything more than influenza, which isn't too difficult to detect in a community simply by looking at the absentee rates in elementary schools. We learned that a long time ago. So where do we get the data? And that is the real problem. And to illustrate what I mean by the difficulties in getting data, I'll take India, where we had set up a smallpox, well, we were concerned about the eradication of smallpox in India. The program began in 1962, before the global program. They were making a tremendous effort, and after 5 years, they had some 8,000 hospitals and health centers that could report cases. It was identified as a priority disease by the government. A lot of money was going into it. Smallpox case reports are compulsory by international treaty under the international quarantine regulations. And in 1967, they reported 83,975 cases. And as we were later to determine by special surveys and looking at pockmarks and what have you, that we guessed that at best it was 1 case in 10. So here you are with a priority disease, obligatory reporting, and you're getting 10% of the cases being reported. Well, we eventually were able to change that, but in October of '73, in one state, the state of Uttar Pradesh, which is admittedly one of India's larger states, we did a search. We did it nationally, but we did it in Uttar Pradesh, and it was in October. They'd been reporting about 500 cases a week, and this is still a low season for smallpox. And they went out, and the idea was to visit every village in the state in a 10 days time. So we get an idea on this and try to begin to stop the spread of the disease. Well, the report, they found 11,000 cases that 1 week after we had 500 a week. 11,000 cases. And this was just the beginning of the normal increase in smallpox season. We were in a state of shock, I must say, and actually accused some of our colleagues of maybe fabricating the data or even not having accurate reports of seeing the cases but only reporting rumors. And we were promptly told that we have data on every single case, sir. So in '73, we did set up a system to get each health center to report weekly. And there were 397 you call them epidemiologists or health officers, to go out and regularly visit them and remind them to report. And then we had surveillance teams, a couple of people to go out and investigate cases, to find other cases, and to take containment measures. In other words, you really had to put in a tremendous amount of effort, when you really come down to it, to supervise this, to make sure that they're getting the reports, and then to come back and they see something happen if they send in the reports that are positive. So that we came to the conclusion, if you're going to do surveillance, it almost has to be disease specific. And this raises real problems. If we're looking for a new agent disease or what have you, what do you have people report? Maybe it's going to be hemorrhagic disease, maybe pustular disease, maybe it'll be some sort of encephalitis that you haven't seen before. So what do you have report? It's really very difficult. So it has to be disease specific. The national authorities must be persuaded, because amazingly in every instance, I think just about every country, there's a lot of objections to having people just going out and investigating cases. This was the term, just going out. They should be vaccinating people. And to go out and spend time chasing after cases, this was regarded as not a good idea. So it took a lot of persuasion to get national authorities to cooperate on this. And then you have to, these reporting sites, they need to have some sort of stimulus to report. And this was regular contact with supervisors, the investigation, these records published in surveillance reports which they saw, so that this, to make the point that something is happening with the data and there's a reason to do something. All of these conspired to help considerably in the surveillance. But there's another interesting thing that turned up, and that was that with the teams moving around, that other disease reports came to light. And so indeed at one point we were getting so many reports of other outbreaks of disease that the teams were getting, we finally had to say, no, we've got to keep focused on smallpox. It may be a hemorrhagic disease up there, maybe something else there. You've got to stick with the smallpox, otherwise we'll never complete this task. So the fact that people were moving around there, that's the way we were getting the information. Well, how do we find out about the disease, and what does history tell us? And we've gone back to look at how did some of these diseases come to recognition. And it really, in all cases, really was an alert clinician, somebody who says, I've got something strange here, and then calling up and getting some help to investigate it and see what it was. West Nile encephalitis was resulted from 2 patients seen by a neurologist who thought that they didn't look quite right. She thought they were 2 different diagnoses, but it was a bit strange. She called up the health department, and Dr. Marcy Leighton went out and said, this looks like encephalitis, a viral encephalitis, perhaps arthropod-borne, like St. Louis encephalitis, perhaps. Well, they've never had a case before in New York City. And so it wasn't something that a physician would think about, but sure enough, it was West Nile encephalitis. And at that time, they determined they actually had 20 cases in hospital that weren't being reported. But it just took one to trigger it. Certainly with HIV/AIDS, this came to light with just a few cases. Ebola hemorrhagic disease has been, I think the experience has been, even in remote areas, that you have a hemorrhagic disease, you have a pustular disease, it's more likely to come to notice, but again, it's just with a few people reporting in, we've got something wrong. We could go on with SARS, and actually our first outbreak of anthrax down, and that's when the first cases, we got that one case that is an alert physician turning to the laboratory. So I think the thing that we would put the most emphasis on at this point in time is what we need is alert clinicians at major sites where very sick patients are to be seen, be it emergency rooms or where. They need access to current information. They're going to need much more than they do now. We need communication here. And there then has to be a need for some sort of contact with somebody who can respond to a call. The response to the call is important. And to illustrate where we were in the United States on this, we were working in 1998, 99 to come up with the first papers to deal with what do we do with these different biologic agents. And I said, well, look, why don't we put an emergency call number for each state as an adjunct to this in the Journal of the American Medical Association? It'd be a good idea, and then they've got it handy. So we began calling up. Well, there were 8 or 10 that didn't have a number. There were an equal number that knew they had a number, but nobody knew what it was. We called up, I hate to say it, the Maryland Department of Health on their emergency number, and got an answering machine and reported a case which sounded very much like anthrax. We made it sound very much like anthrax. And 3 days later, we had a callback. So to say that maybe we're not as alert as we might be is to say, even in this country, we're not doing very well. So that I think this is key. Then an investigation team that can respond promptly makes a very big difference, because, again, it doesn't need to be a big team, but it was the elements we saw with smallpox of people moving around through the area, working on various problems. These things do come to light, and there isn't a better way, I don't think, to get the information such as this in order to get to these new outbreaks that we might see. And actually, at this time, there are a number of developments that are occurring, which I think are encouraging, with WHO, which is heavily underfunded, very little, but really doing very well, and creating a response network involving people in different countries ready to respond immediately for emergency outbreaks should come about. The Canadian government has funded an operation at WHO in which they're screening now newspapers from vast number of newspapers down to the lowest levels, and feeling that these are more likely to get information from there, and indeed they are turning up quite a number of interesting reports. In the Americas, there are a couple of centers now which are really working very well in a combined surveillance and response system, and DoD has a considerable operation with their medical research units, which are really doing a very good job in turning up a lot of valuable material. And finally, the one center, International Health Center, which has really done an outstanding job, is the one in Bangladesh, doing much more than just diarrheal diseases. So there are models that are coming into play, and I don't think there's going to be any sort of overall international single pattern, but I think it's going to be a coordination of a whole lot of different initiatives. So what we're looking at, I think, is the greatly strengthened network of international cooperation and communication, with centers for epidemiology and laboratory diagnosis in most countries, with an ability to respond. And here they're going to need literature, they're going to need reports, they're going to need methods of communicating with each other, and, as I say, a far more generously supported WHO effort. And supporting this in particular as a need is a need for diagnostics that could go very quickly. So let me conclude with just 2 quotes from the Institute of Medicine, a report on threats to health last year. Today's world is truly a global village, characterized by growing concentrations of people in huge cities, increasing global commerce and travel. One can safely predict that infectious diseases will continue to emerge. Depending on present policies and actions, this situation could lead to a catastrophic storm of microbial threats. And to conclude, no responsible assessment of microbial threats to health in the 21st century could end without a call to action. The magnitude and urgency of the problem demand renewed concern and commitment. We have not done enough in our own defense or in the defense of others. Thank you.
We will, the speaker will be prepared to take some questions from the audience if you have them.
Dr. Henderson, with what's going on today in terms of the potential for artificially produced or man-made release organisms, what kind of cooperation is there or should there be between the medical epidemiological surveillance establishment and law enforcement establishment in this country? Because I know you dealt with that in the government.
It's a good question, and in other words, how does CDC epidemiologists get along with the FBI, really? There's an inherent conflict here, and that is that the FBI is, for example, is really accumulating information for prosecution, and they'd like not to have that information divulged. Whereas the epidemiologists are trying to get the information and get it as rapidly as possible in order to develop leads that will carry them on. So this has been an element that has been a lot of discussion at a lot of high levels. That right now there are some training programs taking place in which FBI and epidemiologists are participating jointly. But I think every time we've come up with a new situation, we run into difficulties here where the inclination of the FBI is to keep the material sort of close to the vest. I'll tell one story out of school that I think illustrates this. There was a national program was being developed, as to what we would do for SARS, how we would respond. And of course this inevitably involves local, state and local governments, and federal governments. So we got ready to, this is in final draft form, got ready to go out. And then I said, well, let me bring it to the National Council, which is an open meeting, and National Council on Public Health Preparedness. The FBI people said, no, people, the enemy will find out what we have in mind, and they will get around it, and so we can't make this public. Well, wait a minute. How are we going to have them cooperating in a program we can't tell them about? It's a little complicated. So we do have that intrinsic conflict that's there. This was one of the more extreme examples.
So you mentioned intrinsic conflict, but the last epidemic of SARS, the last cases of SARS were from 8 individuals who were working in labs with SARS. The last outbreak of smallpox, as I recall, was the Soviet Union of individuals who were working with smallpox. Anthrax may have come from an internal source. So there are a lot of efforts to defend us against smallpox and other agents from an external source, but what really is in place to monitor epidemics that come from an internal source, such as the government that's working on these agents, legally?
Well, this is a real problem. You're right, the last case of smallpox actually occurred in Birmingham, England, as a result of a laboratory accident in 1978. And we've had the cases of SARS that have occurred this past year as a result of escape from laboratories. And I think right now there's a lot now being done, and both nationally and internationally, to try to tighten up. There are discussions about we should have fewer laboratories, for example, having the SARS virus. That should be under more stringent containment measures. There are all sorts of things now drawn up in manuals and what have you, and enforcement proposed. But this is a dilemma, because I think we can get so far down the line in making it so restrictive that we're not getting good research out of it, and making it enormously more complicated. And so it's, at this point in time, I'd say it's a very difficult question to know just where that line goes between trying to take reasonable measures to prevent the viruses or organisms from escaping, and the problem of restricting them too much. My concern, frankly, I lean toward the side of saying that we're going to do better being more open and less restrictive. Yes, we can have some cases that occur But I just really don't see, by and large, that this is going to be the risk of an outbreak is small, or the risk of cases coming out is small. It's not zero, and it's never going to be zero. So, but the risk of really not going ahead as we should and getting drugs and vaccines and what have you, I think it's even greater. But this is all a dialogue in progress.
Good questions. Marty?
With suicide bombing becoming kind of commonplace in particular parts of the world, what would be the likelihood, or perhaps how lethal could it be, if you basically infected smallpox in these terrorists and sent them into heavily populated areas?
I'm getting a funny echo and I'm not hearing you very clearly.
I'm wondering if you infect suicide people with smallpox, tell them to go out and disseminate it.
Okay. Yeah, I think this is it's been a theme. I think it's been a docudrama on BBC and a few other places of having 4 or 5 terrorists being infected and traveling around through the country and really starting an epidemic. This is nonsense. The thing about smallpox is that when you come down with a disease, you have the prodrome for 2 or 3 days before you develop a rash. And the people at that time are really sick. I mean, really sick. And they mostly take to bed. And then after a day or two, then they will begin putting out virus. But they're not very good about wandering around the country doing, spreading the disease. So that we look, for example, at the importations of smallpox into Europe before the, let's say, 1950s through 70s, how did the disease spread? Well, 50% of the cases were in hospitals as a result of hospital contact. Another 25% were known to be family contacts. And the other 25% are a mix of unknown and not investigated, and perhaps some in the community, a few. So it doesn't really spread all that well. So that indeed there are many instances of, even in households in developing countries, we've had instances where a mother has smallpox, the baby or child is sleeping with her and doesn't come down with a disease in an incubation period, and maybe comes down later, but may not get it at all. But it can be contagious, but it's not all that contagious. So that the 5 roaming terrorists, we smile about that, but I don't think this is really a problem. The big problem is if they could take that powder, like anthrax, and you remember the anthrax were only about 10 grams used in those envelopes altogether, 10 grams. And so that what you need to do is put it into some aerosolizer. Well, let's say, people use aerosolizers for asthma. You've got spraying things in orchards. There are a lot of aerosolizers around. So that to spray it, and then if it's properly prepared, it can float for a long time in the air and spread. And eventually it'll die out, but probably won't last more than 12 to 24 hours, but it can go quite a distance at that time. So that's really what we're worried about. With anthrax, with smallpox, and so forth. Not water, not food. It's this aerosol that really is the big worrisome.
Very good questions. Young lady?
Would you comment on vaccination for the civilians in preparation for biodefense, specifically when we should be vaccinated? I've heard at least 2 different arguments. One is that we should use available vaccine now because storage and maintenance of the large stockpiles can be costly, and there's always an issue of who is going to be accountable for the quality and the safety of the supply. And the other one was that we shouldn't use vaccine unless it's absolutely necessary, so we should wait till a crisis occurs. So I'd like to know your opinion.
Yeah, just to repeat your question, the question, what should our policy be with regard to vaccination at this time? And I think as we reasoned it through, the people that are at greatest risk are those, like in emergency rooms of hospitals, our ICUs, or public health people who may be out investigating cases who would be doing this before the smallpox was recognized. And so the recommendation was that those who might see patients in hospitals, for example, or in other medical settings should be vaccinated. And that was the program that was started. Well, why don't we think of this being more widely in the population, vaccination more widely? Well, one of the complications is certainly this is the most reactogenic vaccine we have. Protects beautifully, but it also causes nasty reactions. So rather than vaccinate the whole population, we've said it wouldn't be a good idea because of the complications. But there's another thing about smallpox which gives us some confidence that if there were a release, we could then go and begin vaccinating. And this vaccine works differently than other vaccines. In other words, you are protected from the disease even as late as 2 to 3 days after you've been exposed and you can be actually infected. The vaccine works more rapidly, given in the skin, and say producing antibody, than the disease acts because it's inhaled. It's about the best way to describe why you get this peculiar effect. So that once we know that there's some cases of smallpox, then we know we can vaccinate very quickly a lot of people. And so that at this point in time is why I say I don't worry so much about smallpox at the present time. One, it does not spread so rapidly, and we can vaccinate very quickly and stop its spread. And we have now the 200 million doses of vaccine. We have everything. The vaccine actually is in kits ready to go out. We're working now with the states and local areas are working out plans to vaccinate should it be necessary in a big hurry. And the vaccine can be anywhere in the country within 12 hours. So we're in a very different position than we were in 9/11.
Well, I think we sort of run out of time on questions, but you all are invited to what we hope will be a very nice reception following this, and our speaker will stay around a few minutes, I hope. Now, before opening the doors, let me just present a certificate. The Medical Library Association, the National Library of Medicine, hereby named Donald A. Henderson to present the Joseph Leiter Lecture for June 2004. The Joseph Leiter NLM MLA Lectureship provides a forum for scholarly and professional dialogue on topics in medicine, public health, and collaboration. And we certainly have been treated to a very wonderful presentation by you. The dangers seem great. I feel much better knowing that you're still on the side of the angels. It's traditional to say that this and a dime will get you on the subway, but that isn't really true anymore. My congratulations.
Thank you, Bill.
The Medical Library Association, represented by T.J. Toohey, will present a more negotiable document to our speaker.
This will get him on the subway. I'm delighted to be here on behalf of the Medical Library Association. The Leiter Lecture was established to stimulate intellectual liaison between the Medical Library Association and the National Library of Medicine. Certainly happened today, and I have long been an admirer of Dr. Henderson, so I'm delighted to present this to him.
Thank you very much.
Okay. Thanks very much. That was really